abnormal looking chest x-ray. Okay. Now, of course, you'd have a really good chance of being right when you say abnormal. Why? Because we're in a lab and everything's abnormal. Right? In the real world, things are different in the real world, aren't they? In the cold, hard reality of the real world, then you don't know, right? Then it's decision-making time. And normal is a tough decision. It's a very hard decision. Even in bone and joint, normal is a very tough decision. It's not easy. Normal's the one that'll haunt you. Normal's the one, the little voice in your head's going to keep saying, are you sure? Keep looking. Because you can't find anything, and you don't want to miss anything. This one, these are not normal lungs. They are not normal. Well, what's wrong with them? I guess we could put this up here. What looks abnormal about them? Yeah. Yeah.
Nodular.
Yeah, it's all over both lungs, but yet none of the lung looks like this or this. That's homogeneous density. There's still lots of air in there, isn't it? But yet that's not normal looking. These lungs don't look like those over there, and those are normal. There's too much density. It's an increase in the density. It's all over both lungs. It's very subtle, but that's not normal density, is it? That, of course, is in the middle of the chart again, just like that one was there. Bilateral, widespread, non-homogeneous increase in density. And that makes us think interstitial, doesn't it? Mm-hmm. Middle of the chart. And so then we have two decisions, interstitial, because it's either going to be dots or branches. It's either a linear branching spider web reticular or it's dots.
Both.
Nodules. Okay? Well, we can sometimes get a little bit head faked. This has actually got thousands of dots. But sometimes those thousands of dots can kind of make us think a little bit reticular from it. But this is really miliary. And how big is miliary?
1 to 2.
1 to 2, 3 to 5,
That's it.
5.
No.
You know, small side 5 to 8. Because really 5 or less is considered to be a miliary interstitial pattern. In fact, the textbooks don't even split. You know how we do 1 to 2, 3 to 5? The textbooks don't do that. I do that, just for ease of teaching. The textbooks just bundle it and all say, hey, it's all miliary, 5 or less. Sometimes it can be metastasis. We just take and extract that 3 to 5, you know, kidney, thyroid, testicular mets out of it and look at that as a specific size. The textbooks don't do that. The textbooks just bundle it all together. They just say anything that's 5 or less, including even the acinar shadows if they're small size. Those are all miliary. We split them out into these different sizes just because it's easier to learn them that way. The textbooks just bundle it all together. They basically, you got big nodules or you got small ones. And small ones are anything that's miliary is 5 or less. And then they just, you know, pick them out. Well, we might as well just split them out and talk about them as different nodules, which is the way we do it because I think it's easier to learn them that way. These are miliary. The problem with 1 to 2 millimeter nodules is that's a non-specific chest x-ray. Non-specific. So what would we like to know about this patient?
History, occupational history.
Yeah, how long have they had it? We need occupational history. We need to know symptoms. We need to know duration. All of those things are important. Have they been running a fever? Is it high fever? Is it a low-grade fever? Do they have difficulty breathing? And we need to know all of those things. You know, if we were looking at an osteosarcoma in the femur, you don't even need a history. The thing is so classic looking. Who needs a history? Miliary interstitial pattern? We're dead in the water without a history. We don't know anything. And then sometimes you can't even do anything more than, all right, well, here's some things that'll do it. You know, what will be more common to do this would be a viral or mycoplasmal pneumonia. Because remember when we talked about the fun facts of interstitial disease? We said if they're chronic symptoms with an interstitial pattern, it's most likely scar. If they're acute with an interstitial pattern, it's usually going to either be pulmonary edema or it's viral or mycoplasmal pneumonia. Out of the 100+ things that cause interstitial disease, we can distill it all down into that, because that's what it is most of the time. So with an acute patient, viral or mycoplasmal pneumonia would be really up near the top of the list. This was a patient with tuberculosis, but there's no way to know that just from looking at the x-ray. See? There's no way to know that. But this could be viral or mycoplasmal pneumonia. This could also be sarcoidosis. The sarcoid can cause this also. Sarcoid can be reticular, sarcoid can be airspace, sarcoid can be miliary nodular. Without a history, you know, chest is so history dependent compared to bone and joint. It is so history dependent. This was TB. And we'll talk about miliary TB. Miliary TB is almost like a tertiary tuberculosis. We don't talk about it that way, but it's almost a tertiary. You remember yesterday we talked about primary, when we were looking at those list of 7? The first one was primary, and primary had 3 parts to it, didn't it?
Yep.
It was the pneumonia, then the big orange spread and the lymph node involvement, and then disseminating all over. Well, that's in an immunocompetent individual. That's what happens in an individual that's never been sensitized to TB and has a normal functioning immune system. What if it's an immunocompromised individual from the beginning? You know, like an AIDS patient that contracts TB for the first time. They don't behave like that because they're an immunocompromised. Those people can go like from right through primary right into secondary. They don't even stop. They go right through primary into secondary because they're already immunocompromised. The immune system just like doesn't even know what to do because it's already struggled. And they go right through it, right into primary. They can present like this initially. That's called progressive primary TB. That's primary in an immunocompromised individual. So could even be that. This was TB. Tuberculosis.